A very warm welcome, sir. Dr. Bhansali obviously needs no introduction, but it's my proud privilege to introduce him. He is Professor and Head Department of Endocrinology at PGI Chandigarh. He has got the Outstanding Investigator Award in 2019 by WIDF. He has got the Professor B.S. Raheja Memorial Oration 2019. He was bestowed with the prestigious B.C. Roy Award in 2018. He has been the president of the Endocrine Society of India in 2012, received the Professor M.M. Sen ICMR Award in 2009, and the Professor M. Viswanathan Award, RSSDI 2009, Dr. P.N. Shah Memorial Oration Award in 2007. Over and above, he's an excellent human being, a teacher, a mentor to most of us listening to him. Over to our Professor Anil Bhansali for his talk. Dr. Bhansali, are you sharing your slides? Organizers, is Dr. Bhansali sharing his screen and his slides? Yeah.
Now, able to see?
No, sir, you're not. We can't see your screen, sir.
Okay.
There's a button right, you can see, share screen, green.
Yes,
share.
I'm doing, yes.
First, we have to stop your screen sharing, madam.
No, the organizers have to do it. I'm not sharing. The organizers have to stop sharing.
Actually, ma'am, I think Sare shared the wrong screen.
Yeah.
So you have
Now
to take the
okay?
PPT in the background. You have to take the PPT in the background and then share the screen.
Sir knows that. His slides are open in the PowerPoint presentation. Dr. Bhansali, are your slides in the PowerPoint already open in the PowerPoint? I think someone, Hardik, can someone Bhansali, please?
Hello.
Yeah.
Good morning.
Hardik, can you help sir share the screen and just tell him?
इनका होगा यार, मैं अभी आऊँगा
Yeah,
दोपहर
Neela.
2 बजे के आसपास.
Hello. Bhansali sir, there is a green colored saying share screen. Press that. Hello. Yes, we can see your slides.
Sir, click on slideshow mode.
Sir, can somebody help you, Dr.
Yes.
We can see your screen now.
Yeah.
It's not
So now
moving.
it's slides.
Screen.
You know, you learn it now. What did I do it earlier? Yeah, I don't remember. You're not able to, like, this getting a problem. Next time, if you don't know, then you don't need to give it. You have to go here.
Yes.
100 times I've told you, go here.
See.
I'm not.
No share. Sound is okay?
Yeah, we can see the screen, sir. Can you move the
Is
slide?
able to see the slides?
Yes, sir. Just make it full
Yes,
screen,
yes.
please.
Now it is okay?
So just
Yes,
make it
yes.
full screen. Just make it full screen.
Slideshow is okay.
Yes, yes.
Make it slideshow.
Slideshow. Fine now?
Can you please move the slides for him? Are they moving?
Yeah.
They are not, yeah, they are moving now.
Yeah, so.
Okay now?
Yes, Dr. Bhansali, sir. Please proceed with
Yes.
your talk.
Yeah.
So we patiently wait for an excellent deliberation.
Yeah.
Start, sir.
Thank you, chairpersons. Thank you, Dr. Banshi, for inviting me for this great conference. And I will be talking about the DBCD, that is a dysglycemia-based chronic diseases, which is a very integrated, holistic, and a newer concept, which is encompassing from evolution of diabetes to its complications. And important point here is that, yes, the important point here is that this not only includes the complications related to macrovascular, but as well as microvascular. So we can see the key mechanistic drivers for dysglycemia-based chronic diseases includes genetics, environmental factors, and epigenetics. And they are very complexly interacting and eventually leading to evolution of a disease. So you can see that stage 1 is only an insulin-resistant state. Stage 2 is a pre-diabetes. Stage 3 is diabetes, and stage 4 is type 2 diabetes with complications. And the key cell organelle which is involved in this is basically a mitochondria, which has got a defect in carbohydrate as well as in free fatty acid metabolism.
Your slides are not moving.
Possibly because you are able to hear?
Yeah, but little louder, sir, and your slides,
Okay.
don't move them yet.
Yeah, possibly because of the free fatty acid metabolism is impaired, which eventually leads to more availability of the free fatty acids.
Technology people, Dr. Bhansali's slides are not moving, and he is already on a 5th slide.
Bhansali sir, your slides are not moving.
Now moving, sir? Yes.
No, sir. Can you just double click on the screen, sir? Just
Double
double click
clicking.
on the screen. Just anywhere on the screen, double click.
Now?
And now move the slide, sir, with the arrow.
Yeah.
No, sir, they're not moving.
Kindly share it again. It will be moving again.
Or we can hear stir extempore.
No, it is going on now.
No, sir. The
No,
first
sir.
slide, stratification and strategies for CVD risk reduction. They're not moving.
He can speak extempore, but we won't understand all that.
Yeah. This will be difficult, yes.
You please reshare it. It will work.
Yes, I'm sharing.
No issues.
Application window. Yes. Share. Now?
Yes.
Yes. And now, sir, click on this slideshow button.
Yes.
Now click next.
Now moving, sir?
No, sir. Bottom left slideshow button. I think slideshow is not working. You can take one slide by one slide. You can click on individual slides if you can. And
Yes, sir. Click on the second slide now and we can.
Yeah, now it is okay?
No, sir.
No.
You go into the left side and click slide by slide on the left, where we see all your slides on the left.
Can we proceed to the next talk and give sir some time to?
No, man, I will do that. I'll just do that.
yes,
I will
sir.
do again.
We know you will do it. On the left, there is a ribbon of slides, sir. You just click on the slides,
You
individual
just
slides.
go to the slide show. It's on the bar. You see, you read from home to the right, home format thing, and then you see there's a slideshow. You click the slideshow.
Yes.
Yeah. Share screen. Yes, application window.
Just click on slideshow now, sir.
slideshow, sir.
In the top, sir, there is home, then format, themes, tables, charts, smart art, transition, animation, and then slideshow.
But sir, I'm not, because slides are already okay.
Hello.
No, I think it's your cursor still not moving.
Yes, yes.
Your cursor is still on the first slide where you do the formatting. So you should double click, get out of it, do a double click, get out of it, and then go to slideshow. Because you are now at the formatting.
Yes.
Now it is okay?
No, it is not okay, sir. You have to do on the
slideshow now.
slideshow. You have to come out of it. मीना, मैं सुन रहा हूँ, मैं हार गया, लेकिन वो
Not coming?
No,
सर,
sir. not coming.
आप एक्चुअली डॉक्टर अनिल बंसाली, आपने गलत जगह कर्सर लगा रखा है. आप इसमें से बाहर निकल के साइड में स्लाइड शो दिख रहा है, वहां पर स्लाइड शो पर टिप करिए.
Where's your cursor?
डॉक्टर अनिल बंसाली.
Yeah, cursor is this.
Problem is the cursor.
Yeah.
आप
Go to slide.
आप स्लाइड शो करिए. ये यहाँ नीचे लेफ्ट के अंदर आपको दिख रहा होगा, जहाँ 4 टिप के बने हुए हैं. उसके बाद में आपको वहां पर क्लिक करना है.
4 टिप, एक जस्ट
बॉटम लेफ्ट में सर 4 टिक हैं, उसके बगल वाला slide.
आपके लेफ्ट के अंदर दिख रहा है डॉक्टर अनिल बंसाली, आप देखो वहां पर आप अपना माउस ले जाके वहां क्लिक करिए. आप या मेरे को वीडियो कॉल करिए ना फोन के ऊपर, मैं आपको फोन पर बता देता हूँ.
sliding move.
Send me the slide so I can run from my side.
Yes. चलो वहां पर नहीं चलिए.
Is anybody is there with you?
Yes, yes, yes.
Yes,
So
we can now see your 6th slide and your cursor also. Just click on the slide show, sir.
कर्सर को आप नीचे लेके जाइए.
ये लेफ्ट बॉटम लेफ्ट
ये
ये सर इसके पास वाला ये.
हाँ,
यस,
अब
वेरी
इसको
गुड.
क्लिक कर दीजिए.
Okay now?
ना आपने क्लिक नहीं किया वहां पर. आपने अभी भी जो 4 टिपके बने हुए हैं, उसके बाद में जो पावर पॉइंट स्लाइड शो आता है वहां पर क्लिक करिए. नीचे और इसके आगे सर आप कहाँ जा रहे हैं? वहीं ये वाला क्लिक करिए. क्लिक करिए. इट इज नॉट गेटिंग.
तो सर टेक स्लाइड बाय स्लाइड, वन स्लाइड.
सर ये आपका उसमें ड्राइव में से है, आपको राइट साइड में ऊपर जो प्ले बटन दिख रहा है ना सर,
प्ले बटन. हाँ प्ले बटन
वहां से. हाँ
फ्रॉम स्टार्ट, सबसे पहला वाला सर, लेफ्ट में सबसे पहला फ्रॉम स्टार्ट.
सर का वो दबी नहीं रहा है मेरे ख्याल से. हार्दिक उनको ऐसा करो, प्रेजेंटर व्यू के बिना ही करा दो, फर्स्ट स्लाइड से ही कर दे.
ठीक है, ठीक.
सर यू कैन स्टार्ट, देयर इज नो प्रॉब्लम. नाउ यू कंटिन्यू.
Now it is moving, sir.
Yes, you have to. Yes, it is seen. You
Yes,
can
we can see, sir, this way.
Fine.
So from first slide you can start.
Yeah, it's moving.
Moving now?
Yes, sir.
It is moving.
Very much.
Start with the first slide.
Yes.
Please go ahead, sir.
Okay, my sincere apology for the this technical hassle. So I will be talking about the DBCD, that is a dysglycemia-based chronic diseases. It is a new concept which is comprehensive and integrated approach encompassing from the evolution of disease to the complications. And here we can see that this not only includes the macrovascular complications, but this also focuses on microvascular complications. Very interestingly, this has also been involving the cell organelle, which is of great importance for diabetes, and that is mitochondria, and altered metabolism for the free fatty acids and glucose that eventually leads to more availability of the free fatty acids into circulation and ectopic accumulation, and eventually leading to adiposity and insulin resistance. So the whole system now focus of this DBCD is on mitochondria. That's one. It's a very holistic approach from evolution of a disease to complications, And that's why the strategies are now planned to target the different stages so you can prevent the diabetes even from the population-based approaches or population-targeted approaches. So this includes the stage 1 is insulin resistance, where the adiposity is the main characteristic feature, followed by the pre-diabetes, that is stage 2. Then the biochemical abnormality more worsens, then you have got a diabetes, and eventually the long-standing diabetes along with multiple comorbidities to develop so many diabetic complications, both microvascular and macrovascular. The approach in DBCD is now also focusing on mitochondrial epigenetics. As I mentioned, the mitochondria is integrating cell organelle for two basic metabolism, fat and carbohydrates, and this 17 beta oxidative machinery becomes impaired or becomes defective, whether it is because of mitochondrial loss or whatever the mechanism may be, that eventually leads to more free fatty acids in the circulation and eventual adiposity. So the primary culminating event is adiposity, and that is possibly because of the altered mitochondrial function. And this shows that even in thin fat Indians, where you have a more visceral obesity, more abdominal fat, the fat cell size is even smaller. The larger adipocytes, we have a more larger adipocytes than the smaller adipocytes, which are more insulin sensitive, and they may be possibly more dense into the visceral compartment. That's why the thin fat Indians and eventually leading to the adipokines, which are both pro-inflammatory and decrease in adiponectin, and eventually leading to insulin resistance and type 2 diabetes, and so many consequences of this insulin resistance as a dyslipidemia, endothelial function, hypertension, oxidative stress, and atherosclerosis. So the culminating event for the first stage 1, that is a stage of insulin resistance, possibly your visceral obesity is playing a role, and possibly at that point of time, the altered mitochondrial function may be responsible for this adipogenesis. If you look for the metabolic drivers for this dysglycemia-based chronic diseases, there are 6 parameters have been incorporated, but I think the most important is obesity. If you take normal weight as 1, then the obesity is around 900 folds relatively higher for causing this. And for a stage 2 pre-diabetes, the risk further increases. So you can see that the most important metabolic driver among all, physical activity, obesity, smoking, hypertension, and lipid abnormalities, the obesity is playing an important role in evoluting the disease. It's a global problem. It is not only a problem in India. We had earlier published our data of mortality in patients with diabetes, which was mainly attributed to infection. But that was a 15 years earlier data, and now the data are again changing. So we also now encounter majority of patients with diabetes, they are dying of CVD or they are dying of CKD. This is the data from our own country. The 27 years data shows the increase in prevalence of cardiovascular disease, stroke, as well as ISD that is rising. Another thing which has come into play, that why from evolution of a disease from insulin resistance to pre-diabetes and diabetes, and what happens to the cardiovascular disease in initial stages before the development of diabetes. This has been called a ticking clock hypothesis, means the clock starts ticking even prior to the emergence of hypoglycemia, and this clock starts ticking because most of the comorbidities like dyslipidemia, like obesity is already there, hypertension, or hyperinsulinemia and hyperproinsulinemia all contributes to cardiovascular disease. So meaning by that, the pre-diabetes, which is a window period, maybe encompassing from 7 to 9 years, that window period basically leads to accumulation of so many comorbidities and eventually leading to complications. So what I mean to say that the clock starts ticking even from stage 1 when the insulin resistance starts emerging by accumulating more visceral fat. The glycemic control and cardiovascular risk. The glycemia, in fact, the hyperglycemia, like if you see the data from DBCD, the microvascular complications, they are significantly reduced with euglycemia. Similarly, in the UKPDS, you also find that there is a reduction in cardiovascular events. However, in a 7-year follow-up, it could not achieve a statistical significance. But if you see the data, in the follow-up of the 15 years, the cardiovascular disease also reduced and mortality reduced. But if you start intervening late, then in fact the cardiovascular disease and mortality are not influenced. So what we mean to say that the glycemia plays a role, but if you start intervening early and intensively, if you start intervening late, then the glycemia related cardiovascular benefits in fact does not emerge if you start intervening late. But the non-glycemic factors are very important for cardiovascular risk, and even not only for a macro but for micro as well. And this is the data. 2 and 1 millimole of LDL and 0.9% of hemoglobin A1C. The maximum benefit you reap with reduction in blood pressure. However, all contribute. So you have a 12%, 8%, and around 3% reduction in cardiovascular events with blood pressure reduction, cholesterol reduction, and hemoglobin A1C reduction. And even if you reduce a 10 millimeter blood pressure, you see the forest plot very clearly shows that all events, including microvascular events, all are in favor of reducing the blood pressure to a higher range. Even we have so much of facilities now, we have so many targets now, and still our patients with diabetes are still not reaching CVD goals. And this is the data which shows that 81% of the patients could not achieve all 3 goals. So only 20% could achieve all 3 goals. If you cannot achieve all 3 goals, the cardiovascular risk reduction may not be complete. Similarly, the weight loss, which has always been a focus, because once you have accumulated weight and once you have accumulated adipose tissue mass, the weight loss improves cardiovascular risk factors, but that is only in short term. Here you can see that this data shows that the weight loss was associated with decrease in cardiovascular events with this. So even if you have all 3 goals, that could be achieved in 24% of individuals. But in a long run, even you focus on weight loss, the reduction in cardiovascular risk factors is almost same. So meaning by that, the weight loss also loses its efficacy in a long run for reduction in cardiovascular risk factors. The possible mechanism means the other comorbidities possibly takes over, and the adipocyte, one theory which has come is an adipocyte starvation. So even you continue maintaining and sustain your weight loss, the benefit in fact diminishes with time. Statins, which are the prima now the pivotal treatment for the dyslipidemia and remarkably reduce the cardiovascular events in patients with diabetes. So many data from a primary prevention and secondary prevention. And you can also do that whenever you use a low statin lipid lowering therapy, and you have a remarkable reduction, but there is still residual risk, and this residual risk has been added to the remnant cholesterol, which is not rather than LDL cholesterol, which may be contributed for additional risk to the cardiovascular disease. There are many ways. So what we can have learned that if you target multiple risk factors, data from UKPDS, DBCD, and so many trials, including blood pressure, lipids, and all, still you have a residual risk. The cardiovascular risk reduction can be stratified by the AHA ACC classification, and you can have an app, and you can find out the risk of a given individual. JBS3 is a joint British society that you can also do that. And this is a study from Kerala which found very, very appropriate for our Indian subjects. The Framingham score is another score, and ACC they usually overestimate. So that's why they have suggested that you should possibly use a JBS3 score to estimate the 10-year risk and lifetime risk for cardiovascular disease. Here uses a known SDL cholesterol, total cholesterol, and SDL cholesterol from non-fasting samples, and the risk stratification according to the therapy and risk. So you can calculate the ACVD risk, and possibly this data is only confirmed from Kerala, where this score has been used and found to be useful. Now, strategies for further cardiovascular risk reduction. So now we all know that the SGLT2 inhibitors have changed the whole scenario. They have unequivocally shown the hospitalization for heart failure was remarkably reduced. And there was also improvement in a 3-point MACE. However, there was some heterogeneity in these three molecules which are in a forefront. In addition, there was a renal benefits are very, very consistent with all three molecules which we have. But I think that one of the major targets which I talked about the mitochondria, where the really SGLT2 they do have an effect or not. I think the effect is possibly not there. Now, if you can see that the SGLT2 increases free fatty acids and ketones and decreases glucose by glucosuria, and once they are in a mitochondria, these free fatty acids, the only drug which has been found to be having some beneficial effect on mitochondrial fatty acid metabolism is PPR gamma. Otherwise, no other drugs have been shown. So the glucolipotoxicity is reduced by SGLT2, but the metabolism which is altered in the mitochondria, in fact, is not influenced by any class of drug, whatever we have, including DPP4, GLP-1, and SGLT2. If you go further, the extra glycemic effects, we are all aware about that. They do reduce preload, they do reduce afterload. Even the adipose tissue mass is also reduced, and there is improved glycemic control. And in fact, there is a hypouricemia, uric acid is also reduced, and there is a more sodium excretion, and there is a improvement in systemic vascular resistance. So these are the probable mechanisms for that. Mainly intrarenal effects, sodium excretion, and intravascular effects, and eventually leading to renal protection because of a restoration of the tuberoglomerular feedback, improvement in heart failure and cardiovascular protection. And this is to show that those patients who had an established CVD, they do better than those who have the CVD risk factors. That was some heterogeneity. So now we can look for that. So now the focus is on mitochondrial targeting for glucolipotoxicity. Does it matter? So let us see that whenever there is a mitochondrial dysfunction, in whether this is because of uncontrolled hyperglycemia or whether it is because of an increase in ROS, reactive oxygen species, this interferes with the oxidation of the fatty acyl coenzyme A, which leads to accumulation of the diacyl glycerol and ceramides. This leads to more ROS and eventually interferes with insulin signaling pathway. I think question is that how important is this mechanism, because the two principal substrates which are to be metabolized, free fatty acids and glucose, are all taken care by the mitochondria. You require a glucose metabolism and ATP synthesis for insulin secretion, as well as you also require a free fatty acid metabolism in fasting state. So there is always a metabolic switch and there is a metabolic stability. So a time comes when you have a free fatty acid metabolism and a time comes when the glucose is metabolized. So mitochondria plays a very, very pivotal role in energy generation. So what happens that when there is a mitochondrial overload or mitochondrial dysfunction, there is a decrease in mitochondrial pyruvate uptake and lipid oxidation. There is a decreased substrate for ATP generation, and eventually this leads to accumulation of glucose and lipids into the circulation, glucolipotoxicity, which impairs the insulin signaling pathway, MAP kinase, and microvascular complications. So I think why the focus is shifting from mitochondria, because the fuel metabolism, the predominant cell organism is mitochondria, and this is based on this. So unmet need for an ideal drug which can target the metabolic flexibility or metabolic inflexibility. In fact, metabolic flexibility means the mitochondria are adapted to metabolize the need what they have. But because of the disease process, they are not able to work effectively. That's why the term coined, which is a metabolic inflexibility. So out of all the available drugs so far, except the PPR gamma, which I talked about, that the metabolic inflexibility and including the respiratory transporter chain 2, 3, and 5. So they are related to endothelial dysfunction and leads to more insulin resistance and other cardiovascular risk factors, including hypertension, dyslipidemia, and vascular risk. So to summarize, the DBCD is a comprehensive and integrated approach to target metabolic disorders, encompassing insulin resistance to T2DM and cardiovascular disease. And I will mention it is not only CVD, but it is also microvascular, because particularly diabetic kidney disease is also an important risk factor for cardiovascular disease. The multiple risk factor intervention at an early stage of disease delays or halts the progression of CVD, but remain elusive in addressing residual risk, because their residual risk is possibly because of mediated by the like remnant LDL, which I talked about that, and we also talked about the mitochondrial dysfunction, which can also contribute to worsening or residual risk to cardiovascular disease. The mitochondrial dysfunction is a hallmark in T2DM and attributes to beta cell dysfunction and insulin resistance. The therapies which can target the mitochondrial health may be rewarding in preventing the complications related to risk factors, particularly hypertension, dyslipidemia, or related to hyperglycemia, because both will be helping us in improving the mitochondrial function and eventually the improved bioenergetics of the system. Thank you for your patience hearing. I hope the subject was slightly new, so that's why some audience may not pace with me, but I think I was able to make it clear that the now focus is shifting from onset of disease or type 2 the established disease, from established disease to a evolution of a disease to eventually to complications, and seeing a holistic approach to disease. Thank you.